Hello everyone, this is your first recording on NSG3009 study guide for test number 1. I decided that I was going to record over the study guide, and you can follow along with the study guide as well as look up answers through your PowerPoint presentations as well. So I'll just start with question number 1. Question number 1 says, know the difference between objective, reflective, subjective, and introspective. So those definitions. Subjective data, we all know, or what the person says about him or herself doing history taking. Objective data is, or what the health professionals particularly observes by either inspecting, percussing, palpating, or auscultating during the physical examination. When one person reflects, that's when they look back on behaviors or things they've done in the past, and really they're thinking, what, can that behavior or thing do, or how I can make it better the next time. And introspection is when a person uses a way they're looking inside themselves. So a lot of times a person may be introspective about maybe feeling a certain way about a behavior that a person does or something like that. So those are the definitions, and be able to look at those definitions and put those definitions within a scenario particularly. Question number 2, know what type of information is in a database. Remember earlier in chapter 1, you can reference page 2 in your textbook. We talked about introspection. We talked about databases in particular. And when we discussed databases, we talked about there being different types of data. So you would look like on your PowerPoints, or you can look at chapter 2 and you can see where it has complete or total health databases, episodic or problem center databases, follow-up databases, and emergency database. And remember how we were saying about the different things that's within those databases. But if you was to look at specifically like a complete total health database, that would include a person's complete health history, the full physical examination, and also in a database it would describe current and past health states and form baselines, like with vital signs and stuff like that, baselines to measure all future changes. So those databases are what really yields you doing your first diagnosis. So even though you might have an episodic or a problem center database, for instance, that would just be based on that one problem that a person has at that particular time. Follow up, we talked about that. We discussed how you identify whatever problems, and then the person, when they come back, you want to make sure that they haven't gotten any worse, or you're really looking for them to be better, and then you're changing know any changes that may have occurred. Emergency database, you're collecting data, and it's often compiled like based on life-saving measures. So basically, it's just that you want to know what's within a database. So when you're collecting information, when you're doing a physical examination, you're trying to figure out what's within the database. So if you saw something on an exam, you would be aware that, okay, this particular thing is within a database. Question number 3, know about the levels a person would have when they're doing priority setting. And we talked about this when we did your in-class examination, like, you know, your quiz, pre-lecture quiz. And one of the questions in particular discussed priority setting. And the reason why it's important for you to know about priority setting is because you want to know who you want to take care of first. So if you look at the different levels of priority setting, that would be an important thing for a person to know. You want to know what level of priority. So for instance, they have what they call the first level, they have the second level, and then they have the third level. The first level, always think first. This is the first thing that you're going to do. Immediate and potentially life-threatening. So you're going to look at the ABCs, the airway, breathing, and circulation, and the vital signs. The second level would be when a person is like experiencing pain, and that may not be considered life-threatening. Any abnormal lab values, because you can correct those, any abnormal finding, any new complaints, and how that person's level of consciousness is. It may have changed. Sometimes people have a UTI, and they'll get confused because they have a UTI, which is a urinary tract infection. Third level is just basically based on any type of knowledge deficits, or a person maybe not knowing how to take care of themselves, a person's activity level, their rest level, how they're coping with a disease process, or any other type of psychosocial needs. So for question number 3, know about the levels of priority setting. Okay, know the nursing process. And when I say in sequential order, what I mean by that is I want you to know the ADOPI. I want you to, what we discussed. You will see that in intro, some things in intro, it'll kind of overlap, and it may even seem like it's a repeat, but that's our way of just like nailing it into your head, like saying, okay, so I want you to know the process, the nursing process, and I want you to know that process in order. And because it's a method of a person problem solving, so that would include the A, which is assessment, the D, which is the diagnosis, the O, which stands for outcome identification, P, planning, I, implementation, which means you're doing something, and then evaluation. So it's very important for you to know that in that particular order, that A, D, O, P, I, E, what it stands for, and what you would be doing in each of those type of situations. Try to think of scenarios where if a person is doing this, what part of the nursing process are they delivering? You know, when you do a NANDA, that's in the D portion. That's the diagnosing. And that's based on the assessment that you find. Okay, so question number 5. What is correct about development of culture? Well, as we said in the lecture, culture has 4 basic characteristics. So please do not put anything else into it. If you want to read up on it more thoroughly, you can reference page 14 in your text. But I'm going to say it again. Culture, it's dynamic and evolving. So it's always changing and evolving. It's learned from birth through both language acquisition as well as socialization. Culture is also shared by all members of that same cultural group. And culture can also be adapted to specific conditions related to environmental and or technical factors. So it's important when you're looking at the text that if you see something and it's not one of those things that's true about culture, you're not going to put that answer, right? Don't read more into it. Don't do no more to it. Okay, moving on. Question 6. Know the difference between, we talked about this, assimilation, biculturalism, and acculturation. Now, I'm going to say this, and we had examples of that as well. And I want you to be able to relate that to examples. I told you about it. So listen to what I'm telling you. Assimilation. Assimilation is actually the process by which a person develops a new cultural identity and becomes like the members. Remember how I said of the dominant culture. So if there's more of these people here, or these people, they're running this area, you know, you're going to develop a new cultural identity based on that dominant culture. And the concept doesn't necessarily reflect your heritage. It may not even be consistent with your heritage. Biculturalism is when a person has a dual pattern of identification. And acculturation is the process of adapting to and or acquiring another culture. So acculturation and assimilation, make sure you distinguish between those 2 particular things. Question number 7. Know the difference between holistic, biomedical, naturalistic, and magical religious perspectives or theories of what one would call illness. So, know the basic premises behind those 4 areas. Okay, so for instance, the holistic, which some people may even call holistic, you really can almost integrate them and put them together. I see where on the study guide I do have them as 2 separate things, but think of it like this. Holistic perspective holds basically that the force of nature must be kept in like a natural balance. So a lot of people, you'll see them doing, remember how I said you'll see those type of people doing herbs, and they're those yin and yang type people and that type of thing. So those are holistic. People that use chiropractors and that type of thing, you may see them or look at them as being more naturalistic too as well. Okay, so biomedical is an example, and I had thought about this, would be like, for instance, the germ theory. And like the germ theory states that microscopic organisms such as bacteria and viruses are responsible for specific disease conditions. They do not look at it like, stress could make a person have maybe a headache or something like that. They more looking at like, it may be a meningitis that's making them have a headache. You see what I'm saying? Even though either one of them could, cause a headache. So think of them as organisms, bacteria, viruses. That's biomedical. Where magical religious perspective holds that there's a supernatural force dominant and it causes illness or health issues in a person. So know the difference between those. Know the concepts of pain. And also for those, you can reference anywhere in your book between like pages 15 through about 18 or so, and you'll come up with those answers. And you can also, as well look at the PowerPoints, and it's up under chapter 2 as well. Know the concepts of pain, questions when assessing pain, and various categories as well of pain. Okay, so pain is, you want to look at chapter 10. So you want to look at chapter 10 when you're discussing pain. So you may have I'm trying to think of the best way for me to explain it to you would possibly be well, let me see. Okay. Let me see. Basically, we know that pain is very subjective, so that you can only evaluate pain based on what a person tells you how severe their pain is. So that's the reason why a lot of times a person, we always tell them, well, on a scale of 1 to 10, because that's the best way that we can basically tell a person something, when it primarily deals with pain. So you got to know that, like, even though there's like variations in a person's perception or how well they tolerate pain, and I discussed that a little bit briefly just based on what I've seen. The nurse should always expect for them to have variations in the expression of pain. And it's well known that a lot of individuals turn to whatever their social environment is for validation or comparison of pain. So just know that there is going to be a lot of different expressions of pain. A person will vary as far as their pain, and culturally norms about how, like, some people are stoic or whatever. Nobody behaves the same way about pain. So even though a person, you could have two people and they could have a large area of where it would look of injury, and it would look like they might have the same level of pain, but that may not necessarily be necessarily true. I do want to talk a little bit more. I wanted to tell you guys specifically about the central nervous system, which everybody knows and should know from their anatomy, that the central nervous system is the spinal cord and the brain. And so basically, just that message of the pain or whatever originates from the central nervous system and the peripheral nervous system, or either both. I want y'all to know about nociceptive pain. Nociceptive pain being that pain receptors are stimulated from injury or trauma or body chemicals released at the site. And then I want y'all to know that neuropathic pain is basically your brain and central nervous system or whatever. It's more like an abnormal processing of the pain message. And so even after an area is healed or whatever, you still may have that area, where you may have pain as well. And with neuropathic pain, the pain receptors actually change, making them more sensitive to any type of stimuli. So that's what I'm saying when I say that it's kind of like almost an abnormal message. So different things like diabetes, shingles, HIV. Have you ever heard of phantom limb pain? These people are actually having pain. Phantom limb is like when somebody gets an amputation and they feel like, my foot is hurting, but they don't no longer have a foot, or fibromyalgia. So that is what you talk about when you talk about different things as far as pain. As far as categories and different types of pain, I would like for you to know, we know that acute pain is usually due to injury, and it usually heals within 6 months. Chronic pain lasts for longer than 6 months, and it persists after healing has occurred. A lot of times people have a normal vital sign because they've gotten accustomed to that particular pain. That is where we are as far as with that, as far as the pain and the illness and the categories and of pain. Let me see. Next, know how to basically I want you to know how to adjust an environment so that basically, like when you're interviewing a person, you want to make that area good for the person, where it's best for you to get that interview done and for it to be the best type of interview that you can do. Of course, that would be from chapter number 3 with the interview portion. And if you want to reference your book, you could probably look at around page 29 in your book. So basically, the nurse, you know, when she come in, she should reduce the noise by turning off the television, radio, or any other thing, any other equipment that, because like if you got a lot of different stimuli going on, that can be confusing. The interviewer and patient should be about 4 to 5 feet apart. You don't want to be too much up on the patient and make them feel threatened, but at the same time, you don't want to be too distant and make it feel like you're not interested in what's going on. The rooms, of course, should be really well lit, and that'll enable the interviewer and patient to see each other clearly. Having a table or desk in between you and who you interviewing, almost sometimes they say creates a barrier. And so you don't want to be looming over the person. You want to be sitting kind of like on their equal eye level, and that would be good. So those are the type of things that you would do. If you look on your book and you reference page about 29, you will see basically what that is, and how to make it successful. As far as, let me see, know the different phases of an interview. Also, I forgot to tell you, when you interviewing a person, and I even saw this when we was doing it in lab, I may have told some people when I was doing checkoffs, but I would really want to tell everybody that you initially always address everyone by their surname, so by their last name. You can also ask them, is it okay that I refer to you by this? Sometimes if you might call somebody by their surname and they may tell you, oh no, just call me Bob, or oh no, just call me Ann, or whatever, but wait on the client to tell you that, or the patient to tell you that. Okay? Know the different phases of the interview. We already discussed the different phases of the interview. Basically, when we talked about the different phases of the interview, we talked about that initial phase of the interview where you were collecting the information. We talked about the working phase. So you got the opening where you coming in, you introducing yourself, and you got the working phase where you're gathering the information, and then you have also the closing phase. Well, I want you guys to know and be able to pick that out if you see that, where you would be like, okay, if they might say that Nurse Susie is doing this, that, and that. What phase is she in on the interview? Okay. Know about the verbal skills used during the interview. Also know about the negative. We discussed that as well. You guys should really know about the different phases, because we talked about the different phases in the interview. I mean, in the form of facilitating. So, like, for instance, okay, you coming in for the phases of the interview, and you got the introduction, the working, and the closing. Some people call the introduction the opening, but introduction, working, and the closing phase. Okay, and you know what to do in each one of them. So when you communicating, remember we talked about facilitating, where you're shaking your head and you're saying, okay, go on, and you're nodding. Reflection, where basically you're having a person remember or repeat. So you're asking you're basically repeating exactly what the person said. And then that encourages the patient to go on and elaborate. We talked about what empathy is. You might tell a person, oh, you must feel frustrated about that, because you could tell by the way that they say things. Clarification, you're basically asking them to tell you what they mean by that. They may use another terminology you may not be aware of. Okay, so clarification, confrontation, we told you you wouldn't tell a person if they in pain that basically they're not. And then we talked about the different pitfalls or negative things that you can do. Remember when we was talking about leading them, talking too much, interrupting, questioning them, saying, well, why, using a bunch of professional words and assuming they know, engaging in distance. Those are the type of things that you will be aware of when you're doing, an interview. So all those things come out of the interview chapter number 3. Know that interaction may differ with a toddler, and what you can do to facilitate it. Usually toddlers, and that they are all over the place, and they're very concrete. And when you say that somebody is concrete, you're basically saying that that person is exactly what you're saying. Oh, you can't say to a toddler, you feel blue. or whatever, because they may think you saying blue mean the color blue. They may not know that that means that it's sad. So, although like most of the communication might be with a parent, the nurse, when they come in and they dealing with like a toddler, you can't completely ignore the child. So making contact will help like ease the toddler doing, like if you're doing a physical examination. And a lot of times you can break the ice by maybe asking about a special doll or a teddy bear or something like that. And oh, let's say they have a toy with them, and you might want to ask, oh, do your doll have a name? And always meet the child on their eye level and stoop down, you know, like on their eye level, so you won't be threatening, you know. Okay, so next, basically, you know what the purpose of health history is, and the whole purpose of an assessment or a health history is to get to collect subjective data. That's basically, because what you're trying to do is you're trying to get what the person says about him or herself. So the whole purpose of health history is to collect subjective data. Okay. Know the focus of a functional assessment. The purpose of functional assessment, basically what it does is it measures a person's ability to administer their self-care. And that's when, I mean, just like on a real general level, can they bathe themselves? Can they walk? And we're talking about even within the absence of them being ill. So that's basically what the whole focus of a functional assessment is. And you can basically look on like page 56 of your textbook when you talk about the whole idea as far as performing a functional assessment on someone. Okay. How would a how would a review of systems of an elderly adult differ from a younger person? Realize that when you are dealing with somebody that's an elderly adult, there is going to some type of adjustments that need to be made. First of all, knowing that they're elderly, you really have to let them reflect, you know, so give them time to process the information and be patient, and also make some type of accommodations if they may be hearing or vision impaired when you're dealing with elderly adult particularly. You can read that type of thing on your study guide. Okay. Know the various assessment techniques and used during a physical assessment. The basic 4 techniques that you would use is inspection, auscultation, palpation, and percussion. So, inspection is basically when you're giving a person scrutiny. You're looking at them. You're making sure that you got good lighting. You might want to be looking at something even like hygiene. Sometimes you use instruments like pen lights, or if you're looking at in their ear, you're using an otoscope to look in there and inspect. You have other techniques that you use. Auscultation. Usually you use a stethoscope for that. And for auscultation, you're looking basically because you're listening to sounds. When you auscultate, you wanna use your stethoscope, and you wanna see sounds that are produced by the body. These sounds could include in the abdomen. They could be actually heart sounds as well. You want to know, what I want you to know is, I want you to know that the diaphragm is for high-pitched sounds and the bell is for low-pitched sounds. That's on your stethoscope. I mean, on your, that would be on your PowerPoint presentation where it shows you. And I want y'all to really pay a lot of attention to chapter 8 when you're looking at this. You're talking about right up around page, I think it's like maybe from 113, 114, 115 through probably about 120 or so. But I know it's like 115 is a good thing. I do want you to know about palpation, which is the sense of touch. Remember in lecture we talked about percussion depicts the location, size, and density of an organ. Palpation, you're looking for the turgor and texture of an organ. Okay, so knowing those differences would probably be important. Knowing the different sounds, as far as we're gonna start talking about sounds like resonance and hyperresonance and those. For the purpose of this test, you may not need to look like right away and really know them, but we want you to start getting it clear. But things that I say over and over again, like I'll say, oh, the stethoscope, the low-pitched sounds, like extra hard sounds or murmurs, is for the bell. The diaphragm is used for high-pitched sounds such as breath and bow and normal heart sounds. I keep saying that over and over again. You need to remember that. Okay. Let me see. So, look, when I say about these techniques and the best use of these techniques and what are they for, which was question 17, and you need to be like aware of those things that I'm telling you, because they I mean, they will be on the exam. Let me see. As far as if you have knowing how to properly use the stethoscope, we basically taught you guys how to properly use the stethoscope when we was discussing it in lab, and that's the reason why we'll have you doing different things in the lab, and we want you to take it all into consideration, like when we had you doing ATI, like for the vital signs and that type of thing. We want you to start feeling comfortable and about that type of thing. When you talk about how to properly place the stethoscope in your ear, for instance, reference page, I think it might be page 116 in your book. We want you to be aware about that. What do you know about the stethoscope? It does block out extra sounds. When you put it in your ear, you don't hear all those extra sounds. Think about that. You know, it does not magnify sound. It don't. It may seem like it magnifies sound, but it doesn't. You know that the slope of the earpieces should point toward the examiner's nose. So going that way. Remember how we kept, like, it's not pointing outward, it's pointing inwards towards the examiner's nose. I mean, well, you could say outward, but it's pointing towards the examiner's nose. If the tubing is too long on the stethoscope, it can distort the sound. And whatever type of stethoscope, the better the stethoscope, the more important. The quality, the better. You know, the better fit, the better quality stethoscope, the more accurate your readings will be. So know about all that. So if I ask you if a stethoscope magnifies sound, you will say no. But does the stethoscope block out? Like, you could have your stethoscope that fits properly in your ear, and that stethoscope, if you're listening to somebody, you really can't hardly hear what's going on outside of you. Know the proper aseptic technique and standard precautions when performing a physical exam. That all goes back to what we was talking about when you performing a physical exam. And what I'm basically saying to you is, we know that you need to be wearing your gloves when there's a potential with any body fluid. So that don't mean you have to wear your gloves all the time. If something was to happen and somebody, so if there's a potential for blood, for body fluids, the nurse should always wash her hands or his hands, put on gloves, and then continue examining the patient or the ulceration if you was to see somebody in that particular position. What's the components of a general survey? Basically, when you take a general, think about it, general survey, look on your reference page at 127, and when you take a general survey, it's a study of the whole person. That includes observing the patient's physical appearance, their body structure, how they built, how they functionality, how they're mobile, and also their behavior. You can reference page 127. Okay? So a general survey means general. And so you're going to look at physical appearance, body structure, mobility, and behavior. Survey. They don't say nothing about no vital signs. It's just saying you taking a general, and that's what I was saying to a lot of people when they was first coming in and they was doing their assessments was, you know, you're going to take a general survey, and that's how you can answer some of those questions when you're collecting your database. So, okay. Let's see. One thing that we didn't discuss too much was about when like, you know how when we weigh a person, for instance, and that is probably would be part of you doing a physical assessment, you know. And what I want y'all to know is when you are weighing a person, make sure that you just use a standardized balance scale so that it's correct. It's on 0 when you first started. And they say that especially when you're teaching a patient to weigh themselves, have them use the same scale on the same platform all the time. And the patient should remove his or her shoes. And if they got some heavy outer clothing, like a coat or a jacket that's heavy, if you have a person that has to weigh all the time, like sometimes when you have a person, and y'all will learn about this with CHF, or as it's called congestive heart failure, one of the indicative signs that person, something may be going wrong with that person is, or they'll be starting to back up fluid, and because they have congestive heart failure, and as a result they'll gain weight. They may gain 2 pounds in one day or 3 pounds in one day. So you might have that person on daily weights. So you want them to weigh at approximately the same time every day, and on the same scale with the same type of clothing, okay, every day, so that you can get the most accurate reading. Because if you have a change and they weigh the 2 pounds, that could be the difference between them going to the hospital or not. So you have to keep that type of thing in mind. As far as the vital signs is concerned, I want you guys to be familiar with the normal ranges of the vital signs. Study that. Of course, in your Jarvis, the vital signs is chapter 9. And I want you to know what we call the normal thing. We can start with the weight, and I told you about the weight because I just mentioned it. It's because we're going to talk about BMI. And they got a table on page 131 where they basically have a BMI calculator. And so basically BMI is important. because it provides an accurate assessment of how much body fat a person has. So I want you guys to get real familiar with 19 to 24 or 24.9 or 25 is considered not even quite 25. 19 to 24.9 is considered a healthy. Underweight is anything less than 19. Overweight is anything above 25 or above. And so from 29.9 to 30 is obese. 35 BMI is obese, class 2, because class 1 was obese, was 30 to 34.9, and extreme obesity would be a 40 plus. However you can memorize it, it's fine. So the waist circumference can indicate a metabolic syndrome, and that means over 35 inches for a woman, over 40 inches for a man. They say that BMIs don't work on people who are lifters because they got so much muscle mass, and it's really not a good indicator in the elderly, because when you get older, you got a loss of muscle mass and you have redistribution of body fat. So, and usually the best indicator of weight or being overweight in children is the growth chart that you use for, basically that's being used for infant. So that's basically how you would probably evaluate, like for instance, a nutritional status. I'm going on to the next question because it just kind of came up. When you're looking at a nutritional status of a person, especially a child, how would you best evaluate whether or not a person is getting adequate nutrition? Well, that would be based on whether or not they growing or not. If they not growing, you know they not getting adequate nutrition. So that's the reason why when you have a child, they always record their height and weight. And it determines whether or not they have normal growth patterns. And that may be related to the fact that they're not getting enough nutrition. I had a girlfriend who was breastfeeding her infant, and the infant was very, very, I remember we was coming up, I was young then. So we was in our baby having phases, and I remember her son, Terrence, he was like really fussy. I mean, he was like a newborn, a week or 2 years old, and he was really, really fussy. And when she went back for her appointment, he had not gained no weight. And it was because she had Crohn's disease, which is a GI disorder. She wasn't nutritionally feeding herself adequately, so therefore she wasn't giving out adequate milk or whatever, or producing it in her body. Therefore, even though she was so-called breastfeeding, her son wasn't getting enough nutrition. So the moment her husband had just had enough and went out to the store and got that baby some milk, it was like night and day. And they had to tell the pediatrician and everything. But she thought she was feeding them, and she really wasn't. The stages of blood pressure. Oh my goodness, yes. I forgot to tell you guys about the stages of blood pressures. What I could say is, I want you to know about prehypertension, which is, believe it or not, prehypertension. So when you have a person and their systolic blood pressure is 120 to 139, so they're saying basically they want us to be below 120. I mean, they almost want people to be perfect. And their diastolic is readings of 50 to 89 millimeters of mercury. And they say that's according to the Joint National Committee. Their what they consider pre-hypertensive. I can't really see how a 50 would be that, but I do know a 120 to 139. And so if you are to look at your PowerPoint that has the blood pressure, and you talk about the systolic, which is the top, and the diastolic, which is the resting pressure, which is the low number. So you'll look on there, and I'm telling you where systolic is when the actual, that's why the number is high, the actual contraction of the ventricles. So that's the maximum pressure. So you'll see on your PowerPoint, I want you to know normal is less than 120/80. Normal. So prehypertension is 120 to 139/80 to 89. Excuse me. And hypertension is, stage 1 is 140 to 159 to 90/99, and stage 2 is greater than 160/100. So I do want you guys to be aware of that. I do want you guys to be aware of that. I knew I was thinking something. I was thinking 59. I was like, no, it couldn't be 59. But I must have accidentally wasn't tripping off of, I don't know what I was talking about earlier. Maybe I'm getting sleepy. But anyway, look at the PowerPoint under vital signs on page number 8. And it'll tell you what the ranges is for prehypertension and hypertension stage 1 and stage 2. So be aware of that. Be aware that it's important that the cuff covers 2/3 of the arm. Remember we told you guys that basically if about the cuff, if it's too big, you'll get a low reading. If it's too too tight, you'll get an inaccurately high reading. Know about that as well. Okay. Know your normal ranges of your temperatures, both in centigrade as well as Fahrenheit. As far as respirations, know the normal amount of respiration. Know that with respirations, inspiration and expiration is counted as one respiration. So in order to count one respiration, the person has to breathe in and breathe out. Know the termination. Know these terminologies. If you look at PowerPoint number 5, you know that the normal rate for respiration is 10 to 20. And it should be easy and unlabored. When you start charting, I want you to start saying it's unlabored. Unlabored means the person is not experiencing any active shortness of breath. So, apnea, apnea, means no respirations. The person ain't breathing. Tachypnea and bradypnea means that like just like you would say tachycardia with the pulse rate, that means that they have a high pulse rate. Well, tachypnea means that they got over the 20 respirations. Bradypnea, just like bradycardia with the pulse rate, means that they got slow respiration, so below 10. Dyspnea equals difficulty breathing. So, we already know that aspect of it. I do hope that you are aware of that. So as far as taking the temperature, you could do rectal, oral, or skin. Oral is the most common. Skin is the most common for infants, and rectal is the most accurate. Know that when you do a rectal temperature, it's always 1 degree above. You know, you have to think of it like, above the core temperature, and then when you do skin, it's 2 degrees less, and normal is 98.6 or 37 centigrade. So know the difference between hyper and hypo. Hyper being like them having a fever, hyperthermia, and hypo being cold. Know that if a person has a fever, it's because they have inflammation. Know that things like a woman menstruating or a person ovulating or exercise or age could cause a difference in the temperature. We have y'all, when y'all was doing y'all assessment prior to taking a temperature in their mouth orally, you want to know whether or not they've eaten or drank anything. So these are things that you are going to ask about. I would like for you to know about the factors that determine the blood pressure. So basically, this is just you reading and knowing. It is on your PowerPoint on page 8 under your vital signs. The factors is determined by cardiac output. So how much blood your heart is pumping. Peripheral vascular resistance. Basically, do you have anything that's blocking any arteries or blockages or anything like that? That could, volume of blood, so how much blood is getting pumped. Viscosity. Viscosity means how thick the blood is. And elasticity of the vessel walls. So you need to know that those 5 things and try to think about it through in your mind and make sense of those things off of that slide that determine or contribute to what your blood reading is. Cardiac output, peripheral vascular resistance, volume of blood, viscosity, which is thickness, and elasticity of the vessel walls. Because if the vessel walls are hardened, it'll be harder for the blood to pump through, and that could raise the blood pressure. So you have to think about things like that way. And we already discussed about ill-fitting blood pressure cuffs, like the fact that if it's too little, it's a certain way, and if it's too big, it's certain low. It'll be too low. So know the difference between chronic and acute pain. We've already discussed chronic and acute pain, about the time variance. The best objective indicator of pain. I think I kind of just went over that. we basically discussed that. I'm trying to think if it's anything that I need to tell you guys about the best indicator of pain. Basically, the best thing or the best person or anything that could tell you about pain would be the individual that's experiencing that pain. Be able to know what the difference is between that. The best indicator of pain would be basically, everybody always says that the person is the best. I don't know if I told you guys that earlier or not, because to tell you the truth, I really think I did. But the best indicator of pain is what the person that's experiencing that particular part. So a subjective report, not objective. We already talked about neuropathic and that type of stuff when I was saying that was an abnormal processing. We talked about those type of pain. When you talk about assessing the quality of somebody's pain, remember I told you about the stages and or principles of pain, and I told you about the different types of like neuropathic and nociceptive, and they do have cancer pain and different pains like that. Well, I want you guys to know and study and memorize those different types of pain. And when you memorizing those different types of pains, I want you to be aware of that like nociceptive pain, that's like way down, like on the cellular level. So I want you to know about that. Sources of pain. I don't know if let me see. I know I said principles of pain and types of pain. I'm trying to think. Classifications of pain, which is basically types. I said acute and chronic. I want y'all to look at the different types of pain. Acute and chronic, which was the type. I told you about that. I told you that men tend to be more stoic, so they say. Hormonal changes are found to have strong influences on pain sensitivity for women, which may be the case. Be able to compare how African Americans, Hispanics, people of color, those type of people react to pain. They say men are more stoic, which means they don't show any emotion. But I told you that I know different. But just go by what is said. Also, they said that African American and Hispanics are usually administered less analgesics. So know the different, know about that. How does older individuals' gastrointestinal tract differ from younger individuals? I know that probably seems like, okay, where did she get that from? basically, I just want you to start thinking about older people, because I want you to start thinking about how as you get older, things tend to slow down. So, usually, people when they're a little bit older, they tend to have more problems with constipation and that type of thing, rather than younger people do. Okay, so let me see. As far as knowing, we talked about BMIs, and I wanted to make sure that I told everybody, I guess, I kind of wanted to just tell everybody how the description of the ideal body weight. We talked about that. We got to talk about cholesterol, because there was a little bit of discussion as far as nutrition as well, and cholesterol levels and triglycerol levels, and that type of thing, like that is like very important when you're assessing a person, because remember, we did discuss that you will be looking at a person and you will be looking at them nutritionally as well. So there are things like that may like impact somebody nutritionally. For instance, if a person is having some type of gastrointestinal symptoms such as vomiting, diarrhea, or constipation, that might interfere with how they absorb food. You know, that may interfere with how healthy or how a person is getting along. So that's something that you may want to take a good look at, you know. So, like, if a person, even if a person is having problems with constipation, everything just sitting there, their absorption is probably impaired if they're constipated. It's very important for you as well, when you're taking a nutritional assessment, to make sure that you ask a patient what medication she's on or taking. And the reason why you ask that when you do the assessment is because certain drugs can affect how a person metabolizes or uses up their nutrients or their food that they taking. So that's very important. You may find people who might tell you that they don't have no taste in their mouth or something anymore. That's important to know. You want to know when that change occurred. If they don't have a taste, that could affect it, because of the fact that if it's not good, they ain't not gonna eat it, you know. It's a difference when you have somebody that's a child and you got a little bitty kid, you know. Most children, a lot of times you want to recommend certain types of food, so you want to make sure that they have nutritious small little finger foods, stuff that they can't aspirate or choke on. There are a lot of reasons, a lot of people, I think I told y'all in lecture that there are a lot of reasons why people, when you reviewing their nutritional assessment, there are things about a person that could possibly affect how they eat. And if a person is financially having a problem, that could affect their whole diet or how they eat. I did already tell you about obesity and knowing the different things about obesity, right? You know, you want to have a low saturated fat diet for people with triglyceride and cholesterol potential problems. You don't want them to have fatty stuff. Increase exercise. If a person is having difficulty swallowing, which may be dysphagia, dysphagia. Dysphagia means that a person is having difficulty swallowing. dysphagia. You know, they may be having inadequate nutritional food or intake as a result, you know, because they are not getting fed right. A lot of times when you're looking at a person's, you might just want to check their mouth, or you might want to check and see if they have a potential swollen gums or ulcerated or bleeding gums in some areas. A lot of times when a person has that, and as you go and you're going to start looking into that person's mouth and how they're functioning like that, you're going to notice sometimes that you'll see certain people and they'll have problems like that, and you kind of are looking and wondering, well, how you know, like, how did that occur, and what exactly does that mean? The fact that a person may have problems, you know, in that matter. Well, it could possibly mean that a person has a vitamin C deficiency, because the vitamin C deficiency causes swollen and ulcerated and bleeding gums. And that is mainly known as scorbutic gums. Also, a person with the bone problems, a person can have what they call rickets. You can read up on that. It's all on page 189 in your book. That's related to vitamin D and calcium deficiencies. And a lot of times that's common in infants and children. And it causes, vitamin A deficiency, A lot of times that causes visual problems. So a lot of times when you look at nutrition, or a person's nutritional status, it's just good for you to know that there are a lot of different things that can occur and a lot of different things that you can assess about a patient that could really assist or assist you with diagnosing, just as you get along, better and stuff. I do want you guys to take a look at some nursing diagnoses that have to do with nutrition, just so that you could be familiar with some nursing diagnoses that have to do with nutrition. So if you was presented, for instance, on an exam with some diagnoses related to nutrition, you would know that, okay, this don't make sense, or anything like that, and just kind of be, aware of it. On this test, I was trying to think if there was something else that I may be leaving out. Oh, I know what I may be leaving out. There are like these disease processes, and if you look at your PowerPoint, especially I think it may be the nutritional PowerPoints, particularly. You can look at those under nutritional assessment, and there's like a couple disease processes in there. I do want y'all, even though I'm not going, it's because there's only so much that I can really, like inform you guys about. I still want to make sure that you are aware and that you look over these things and you do go over the study guide, and you do listen to some of the things that I'm telling you. I'm not going to give you every single little different thing, but I'm going to give you as much, because some of the stuff you kind of almost have to just think about it in a different type of way. You almost have to just think about it, and start getting a little introspective with a lot of the information that I'm giving you. But there are like various conditions and stuff like that that are related to just assessment and as well. And I'm kind of right now, I'm kind of like thinking, did I miss any of them? Because that's kind of what I'm looking at right now. Because I don't want you guys to miss out on anything that I'm doing. But we should be finishing up shortly in a second. Let me see. Everything that I say is important, and you'll find that there's a lot of information. Oh, okay. No, hun, no, like how you go about checking, when you check blood pressures and that type of thing. Remember how you get a blood pressure on somebody that you don't know what their blood pressure. Remember how we was talking about inflating the cuff? Also, this is something that's very important. When you check for a proper size of a blood pressure cuff on somebody, okay, when you check for a proper size, it's important for you to know, like, what the percentage is, kind of what parts of the arm, like, as far as the width and everything like that, that it should be covering. It's important that you know that. So, like, for instance, is something supposed to be covering 40% of the arm? Is the width of it supposed to be 50% of the arm? You know, or that type of thing like that. That's, you know, kind of where I am as far as is that. So like, for instance, you know, like the rubber band part should equal about 40% of the arm. Like, as far as the circumference, the round part, you know, it should go around 40% of the arm. And the length of the bladder, which means the length of the actual, should equal 80% of this circumference. So 40 circumference of the person's arm, and the length of the bladder should equal 80%. So the width 40, the length 80. Okay, so you're talking about the top part of the arm. Okay, and I think we've talked about the different types of pain. We've talked about just about everything. Oh, I do want you to know about marasmus. When we talk about dietary, marasmus is a protein calorie malnutrition, and it's due to inadequate intake of protein and calories or prolonged starvation. And I know y'all have seen that before. And them kids be getting them big bellies and all of that. So it's protein calorie malnutrition. It's called marasmus. Look that up. Marasmus. That's something important for you guys to know. And I know it probably feels like, oh my God, this is so much information. But it's always like that. It's always like that. And I'm just trying my best to get y'all where, you know, like something, a little bit of something. And we talked about the vitamins. We talked about the priority levels. When we talk about, you know, with an open end, we talked about that. Know the purpose of an open-ended question. Know what we checking for as far as PQRSTU when we talk about pain. Know what things you're assessing. What does that PQRSTU? Because you hear us say that quite a bit. What does that stand for? And then, I think at the bottom of the study guide, I have I have we know about that. Micrograms to milligrams and milligrams to micrograms, converting them, and know how to calculate milligrams into milliliters. If anybody is having any problems with their math, please come see me before Wednesday. Y'all know I'll be there. You can just pop in. On Tuesdays, I'm there from 8 to 11. On this Monday coming up, I'll be there all day. You could come in to the open lab. I'm there to just help everybody on whatever they feel they need help with. And for some reason, I'm feeling like missing out on something, or forgetting to let y'all in on something. But if I think of anything as far as the exam, anything that I didn't go over with you guys, cause right now I'm just scanning over my exam that I made and making sure that I did cover, like, as many concepts as possible, or all the concepts that have to do with what we were talking about. And I'm telling you to make sure, no matter what you do, please, 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 take this stuff very serious. Oh, I know what. I want everybody to look up the terminology. And you may wonder, what does this have to do but with what we're learning? But it actually truly does have something to do with it. I want you guys to look up the word acromegaly, and it is on one of your PowerPoints. acromegaly, acromegaly. And I want you to discover, like, if you saw somebody, this is the reason why this question was put in here. If you saw someone and they had this acromegaly, I want you to be able to tell me what you would see when you saw this individual. Acromegaly. Look that up and tell me what that is. Okay? And I think I've gone over just about everything and tried to make it clear. So, have a good one. Have a good one, and good luck. And everybody, please feel free to give me a call, because I'm here to help no matter what you need. And we're going to do fine. Just feel free to give me a call. Okay, good evening, and